America that different cultures simply tolerate children's behaviors in different ways. And when we're looking at normal or abnormal behaviors or behaviors that are impacting children on a daily basis, we must understand it in the context of culture. How does this play a role, for instance, when we're working with immigrant cultures in a country like Israel? We have to understand where the child and where their parents came from, because the way we interpret their behavior is going to be different. It will be very unusual, for instance, for a British-born immigrant female child to come to the attention of their Israeli teacher. Okay, because that child is probably sitting very quietly at the back of the classroom, behaving impeccably and maybe completely inattentive and not coming to the attention of the teacher for a referral for ADHD. So those cultural influences are huge. And diagnosis and treatment is very, very much influenced by culture. I see kids in the clinic from a variety of different cultures, and the way parents rate on the subjective behavior forms that we provide them with is really interesting. The literature is very clear that there's not a great correlation between objective measures and subjective measures. So are we measuring the same thing, or are we measuring different things? And how do we account for those differences when we make diagnoses? When we're making an ADHD diagnosis, we have to be culturally competent as clinicians. We have to understand the parents and the children and the culture that they were raised in and the culture that they're living in and how those things interact with each other. So I think that we know as clinicians very clearly that the etiology of ADHD is a very complex interplay of genetic and environmental factors. I mentioned Asian cultures earlier. There's some really interesting discussions in the literature about how we look at ADHD from different cultural perspectives. One of the articles that I read recently talks about how ADHD medication in China is thought of as the wise drug, because in that culture, the desire for children to be smart causes parents to want to do whatever it is that they can do to increase the child's learning capacity. And that's a way that parents view this particular medication. We know lots of things about socio-economic status in ADHD diagnoses, also a cultural type issue, in the fact that lower socioeconomic status families tend to have higher rates of ADHD diagnosed in their children. So I think the push here, when we look at cultural issues, is really making a push for culturally sensitive norms. One of the things that I know or had in the development of the MOC, so that there are culturally sensitive norms from a number of different cultures. And I think that's important. It certainly brings up the issue when we're dealing in an immigrant culture of what norms to use. And that's an issue that I face on a daily basis when I'm working with bilingual kids who, some of the English-speaking kids I work with may have been born here in Israel, but they're being raised in Israeli culture outside of the home, but inside the home, their homes are very British or very American or South African. Some of these children even don't have very good Hebrew. Which is a very interesting space to be, because you wonder sort of how this develops, but we'll talk about the impact of language. I'll talk about that in a minute. But the measurement issue is clear. What norms are we using when we are using either subjective measures, like rating scales, or when we're using objective measures like a MOXO and other types of tests? Let's go on to the next slide. I'm going to just mention some gender issues. We've heard from almost every speaker today, and I'll just reiterate that boys are much more likely to be referred and to be treated for ADHD. Girls are much more likely to be missed. They're less disruptive in the classroom, and therefore they're less likely to be referred. So this becomes very interesting, because when we look at the epidemiology suggests that boys have a higher rate of ADHD than girls. But I guess it depends very much on how they're being referred in the first place. And there's sort of a referral bias here. Another speaker mentioned that girls seem to have better coping mechanisms, and they better mask or they better manage their symptoms. I think if we look at this from a neurological perspective, sometimes I think about this in terms of maybe the larger corpus callosum that we see in girls versus boys, and the fact that girls are much better at multitasking and boys seem to be better at sequential tasking, and that might be playing a role here too. So the gender ratio rates that we see in the literature from anywhere from 2 to 1 to 10 to 1, depending on where we're looking, suggests that it has to do a little bit with how referral actually happens. We know that boys are very much more likely to have comorbid externalizing disorders and girls much more likely to have comorbid internalizing disorders. I find that in my clinic referrals, and not only have I been working in Israel for 7 years, but I had almost 20 years of a large clinic in the US. And I found there and here that girls are much more likely to be referred for a neuropsych evaluation for learning disability. And what we find along the way, because we know that kids with ADHD have about a 50% comorbidity rate for learning disabilities, we find along the way that these girls often have attention deficit disorder as well. And not surprisingly, children who have language delays are often referred for an evaluation of ADHD. It's in the literature, and Itai, one of your studies that you were involved with in 2020 also mentions the association between language delay and ADHD. It's always interesting to me when I get a child who has very poor skills in their instructional language that the referral is often for ADHD. So imagine that you're sitting in a classroom and the teacher's blathering on in a language that you don't really understand. You're going to switch off pretty fast. So these kids will often get that referral, and they will, if we're not looking carefully and we don't bother to look at the language issue, or we don't evaluate it in the context of a good assessment, we may make a misdiagnosis. In attention, of course, it's a cycle. It's correlated with poorer academic skills, and language delay also plays a role here. So if you don't understand what's happening, you switch off, you're not picking up the skills that are being taught in the classroom, and then anxiety plays its role too, and we get a whole mishmash of all of these disorders going on in a comorbid fashion. So I want you to pay attention to the fact that girls are much more likely to get a referral for a learning disability diagnosis, and therefore we want to be very careful that when that referral comes, that we're looking carefully at attention deficit diagnoses as well. There has to be a really careful analysis of even what language we are testing kids in. I've seen some awful stuff here where kids who are not fluent Hebrew speakers will be tested in Hebrew, and obviously their intellectual scores look a lot lower than really is the case. We have to be aware of the fact that it takes 5 to 10 years for academic language to come into play. It only takes 6 months to 2 years for interpersonal language competence. Basic interpersonal competence, language competence comes into play fairly fast. These kids can chit-chat on the playground fairly well, but they may have very weak skills in academic language. What's interesting when I'm working with this population here is that I find some of these kids are almost sort of alingual in the sense that at home, let's say they're being raised in an English-speaking family somewhere in Israel. At home, what do kids talk to their parents about? There's lots of research about how parents don't speak to their kids very much on a daily basis, but kids and parents talk about what they're going to eat for dinner, maybe what they did at school, maybe what activity they're going to after school, maybe what clothes they're wearing in the morning if we're talking about younger children, but it's a very limited vocabulary. And if they're going to school and their Hebrew language is not very good and they're not understanding what's going on at school, it turns out that their Hebrew vocabulary isn't so strong either. And when you start to actually evaluate vocabulary in both languages, there's not a whole lot going on there. And so these kids are very, very likely to be referred for inattention to our clinic. So it's important that when we evaluate the kids, that we evaluate them in both languages, that we evaluate the skills in both languages. But when we're doing tasks such as the motto, really important, I mean, this may seem trivial to many of you, but it's really important to make sure that you're playing the instructional language in the language that the kid is strongest in. So that they really understand the instructions of what it is that they're doing.